Welcome back to The Deep Dive, the podcast that gets you prepped for your FRCS plastic surgery exam.
Yeah.
Today we're focusing on wrist arthroscopy.
Okay.
We've got a mountain of sources for you.
Yeah.
All about prepping the patient, understanding those crucial portals,
Right.
and navigating the ins and outs of diagnostic procedures.
Uh-huh.
We'll even tackle the TFCC, that tricky triangular fibrocartilage complex.
That's right. And we're going to do it all efficiently, just like a good surgery.
Okay.
No wasted time, straight to the essential knowledge you need to know.
Exactly. Think of this as your express lane to mastering wrist arthroscopy for the FRCS.
Right.
So before we get lost in the details,
Yeah.
let's establish why wrist arthroscopy is such a huge deal.
Well, it's evolved from a simple diagnostic tool to a powerful treatment method for a whole range of wrist conditions.
Yeah.
It's like having a high-definition window into the intricate workings of the wrist joint. While physical examination and imaging give us valuable clues, arthroscopy provides that ultimate confirmation and often allows us to address the problem then and there.
Okay, so let's imagine we're in the OR, ready to perform a wrist arthroscopy.
Okay.
How do we get our patient set up for success?
Think supine and secure.
Okay.
Your patient is lying comfortably on their back under general anesthesia
Yeah.
with their arm abducted.
Okay.
We use a wrist tower to stabilize the hand and apply finger traction for a clear view of the surgical field.
And remember that tourniquet placement is key, right?
Absolutely. Position it proximally on the arm to avoid any interference with our instruments and ensure a bloodless surgical field.
Okay.
Now let's talk about the tools of the trade.
Okay, so we got our patient prepped and draped.
All right.
What instruments are absolutely essential for wrist arthroscopy?
You'll need your wrist tower, finger traps for that traction, and a high-quality 2.7 millimeter 30-degree arthroscope, that's our eye into the joint.
Okay.
Then there are the basics.
Yeah.
A hook probe to palpate structures, a thermal probe for coagulation, and a mechanical shaver to debride any damaged tissue.
So those are our must-haves.
Right.
But sometimes we need specialized equipment, right?
Right, exactly.
What are some examples?
Depending on the specific procedure, you might need biters and graspers to manipulate tissues,
Okay.
or a TFCC repair kit if you're addressing a tear in that area.
Right.
Think of it like this. Your basic setup is like your everyday car.
Okay.
But sometimes you need a specialized vehicle, like an off-road truck,
Yeah.
to handle tougher terrain.
That's a great analogy.
Yeah.
And before we even think about making an incision,
Yeah,
we always double-check our equipment.
absolutely.
Camera, monitor, lighting, everything needs to be perfect.
Right. We want a crystal clear picture of the joint.
Yeah.
And here's a valuable tip. Save those arthroscopic images to a USB drive.
Okay.
They become a fantastic resource for future reference, teaching, and even patient education.
Great advice.
Thank you.
Okay, so we've got our patient prepped, our instruments ready, and a clear picture on the monitor. Now, how do we actually get inside the wrist joint?
That's where portals come in.
Okay.
There are strategically placed entry points into the wrist.
Right.
To understand them, we need to visualize the extensor compartments on the back of the wrist.
Okay.
Portals are named using a two-number system that indicates the interval between these compartments.
Okay, I'm visualizing those extensor tendons now.
All right.
So let's break it down.
Okay.
What are the most commonly used portals for the radiocarpal joint?
For the radiocarpal joint, your workhorse portals are the 3, 4, 4, 5, and 6R.
Okay.
You'll find them tucked between the extensor tendons.
Yeah.
The 3-4 portal, nestled between the extensor pollicis longus and extensor digitorum communis tendons, is the most frequently used viewing portal.
So the 3-4 portal is like our main window into the joint.
Exactly.
Can you walk us through how to create it?
Absolutely. First, we apply traction to the wrist and identify key landmarks, including Lister's tubercle, that prominent bony bump on the dorsal side of the radius. Our 3-4 portal is located about 1 centimeter distal to Lister's tubercle.
Lister's tubercle is our landmark. Got it. What's next?
Before making our incision, we use a needle to confirm we're in the joint space and inject a little lidocaine with epinephrine.
Okay.
This helps with hemostasis, keeping the surgical field clear for optimal visualization.
Smart move. Less bleeding means better visibility.
Yeah.
Then we make a small incision and dissect down to the joint capsule.
Precisely. Once we reach the capsule,
Yeah.
we carefully pierce it, insert a blunt trocar,
Yeah.
and for wet arthroscopy, we initiate inflow to distend the joint.
Okay, we're in.
All right.
The camera's focused.
Okay.
The joint is distended. Now what? What are we looking for?
The first thing you'll likely see is the vascular tuft,
Okay.
a small cluster of blood vessels
Yeah.
marking the radioscephalonate ligament,
Oh, okay.
sometimes called the ligament of Tester. Then locate the scaphoid, lunate, and trichotrum.
Yeah.
They will appear superiorly in your view.
And looking inferiorly, we should see the articular surface of the distal radius
Right.
with its scaphoid and lunate fossa.
Don't forget the TFCC.
Okay.
It'll be sitting inferior and ulnar to your 3 to 4 portal, resembling a trampoline stretched across the ulnar side of the wrist.
We've found our bearings.
Okay.
Now, how do we systematically examine the joint to make sure we don't miss anything?
We meticulously inspect both the radiocarpal and midcarpal joints.
Okay.
We're checking the integrity of all ligaments,
Yep.
the smoothness of cartilage surfaces, and looking for any signs of inflammation or those pesky, loose bodies that can cause so much trouble.
Okay, we're looking for anything that could be causing our patient's symptoms.
Exactly.
What if we spot a ligament tear,
Yeah.
especially in the scapholinate or lunar-trichotral ligaments?
Right.
How do we classify those?
We use the Geisler grading system, which helps determine the severity of the injury. Okay. This system grades tears based on the amount of gapping between the bones. The higher the grade, the more significant the instability.
And how do we assess cartilage damage?
Okay.
What systems do we use for that?
The outer bridge system is a classic.
Okay.
It grades cartilage lesions on a scale from I to IV,
Yeah.
from softening to full thickness loss, exposing the bone underneath.
Oh, wow.
Think of it like assessing the ripeness of a fruit. Grade 1 is a slight bruise, while grade 4 is completely rotten.
So grade 4 is the worst case scenario for cartilage.
Yes, it requires a different approach, often involving more complex procedures.
Right.
Now, there's also the ICRS system,
Okay.
which is more detailed, particularly for grade 2 and 3 lesions. This system helps us characterize the size and depth of cartilage damage more precisely.
That makes sense. The more information we have,
Yeah.
the better we can tailor our treatment plan.
Absolutely.
Now, let's talk about the TFCC,
Okay.
a common source of wrist pain.
Ugh, the TFCC, that intricate structure that often keeps us on our toes.
It seems like a complex area. Can you break down the anatomy for us?
Sure.
What exactly makes up the TFCC?
Think of the TFCC as a team of structures working together to stabilize the ulnar side of your wrist.
Okay.
We have the articular disc,
Right.
the dorsal and volar radial malar ligaments,
Yeah.
the meniscus homologue,
Okay.
the ulnar collateral ligament,
All right.
and even the sheath of the extensor carpi ulnaris tendon, all contributing to a stable and functional wrist.
That is quite a team, and I'm guessing there are many ways things can go wrong with the TFCC.
You're absolutely right. That's where Palmer's classification system comes in.
Okay.
It helps us categorize TFCC abnormalities.
Okay, tell us more about Palmer's classification system.
It divides TFCC problems into 2 main types.
Right.
Type I for those acute traumatic injuries,
Yeah.
often from a fall or a direct blow to the wrist, and type 2 for the chronic degenerative conditions, often linked to wear and tear or ulnocarpal impaction,
Yeah.
where the ulna bone rubs against the carpal bones.
So a patient comes in complaining of wrist pain.
Okay.
What would make us suspect a TFCC issue?
All right.
What's the typical story they might tell us?
They'll typically describe pain on the ulnar side of the wrist,
Okay.
especially with activities involving rotation of the forearm, like turning a doorknob or using a screwdriver. They might also mention clicking, popping,
Right.
or a feeling of the wrist giving way.
Those mechanical symptoms and instability are definitely red flags.
Yeah.
What about during our physical exam?
Okay.
Are there specific tests that can help us pinpoint a TFCC problem?
First, we palpate along the ulnar side of the wrist,
Okay.
looking for tenderness over the TFCC.
Uh-huh.
Then we have some provocative maneuvers.
Okay.
The TFCC compression test involves applying axial load while the wrist is in ulnar deviation.
Right.
If this reproduces their pain, it points towards TFCC involvement.
And I remember learning about the press test.
Yeah.
Remind me how that one works.
The press test is a functional test.
Okay.
Ask the patient to push themselves up from a chair using the affected wrist.
Uh-huh.
This creates an axial load on the ulnar side.
Right.
If it triggers their pain, that's another clue.
So palpation, the compression test, and the press test all help us assess the TFCC.
Exactly.
But we also need to check the DRUJ, right? The distal radial nerve joint.
Absolutely. We're looking for any signs of instability there.
Okay.
We can assess this by gently moving the ulnar head back and forth in relation to the radius, while the patient's forearm is in different positions, neutral, pronation, and supination.
And isn't there a special test called the piano key sign? What is that all about?
That's a classic sign of distal ulna instability.
Okay.
If the ulna is unstable, it might be subluxed or dislocated.
Yeah.
When you push on it,
Yeah.
it can pop back into place,
Okay.
creating a palpable clunk, just like pressing a piano key.
Okay, that makes sense.
Yeah.
So if we suspect a TFCC issue based on the history and physical exam, what imaging do we order?
We start with the basics,
Okay.
AP and lateral views of the wrist.
Right.
These are essential for evaluating ulnar variance.
Right.
This measurement tells us if the ulna is longer or shorter than the radius at the level of the DRUJ, which can contribute to TFCC problems.
Ulnar variance can play a role in TFCC tears.
Yes.
Okay, so we've got our x-rays. What about MRI?
MRI is often the next step, especially if the x-rays are inconclusive or we need a more detailed look at the TFCC and surrounding structures.
Okay.
MRA, which is MRI with intra-articular contrast, gives us the best view of the TFCC itself, highlighting any tears or abnormalities.
MRI and MRA can help us visualize the TFCC and surrounding structures.
Yeah.
So we've gathered all this information: history, physical exam, imaging. How do we approach treating a TFCC tear?
Our first line of defense is usually non-operative management. We'll immobilize the wrist in a long arm cast or splint for 4 to 6 weeks, giving those tissues a chance to heal.
Sometimes we might consider cortisone injections to help with pain and inflammation.
Yeah.
But I've heard they can sometimes delay healing, especially for peripheral tears.
That's a good point.
Yeah.
Cortisone can be a double-edged sword.
Okay.
While it provides relief,
Right.
can also hinder the healing process in certain situations.
Okay, so when do we decide that surgery is the best option?
If non-operative measures fail to provide relief after a few months, or if the patient has significant instability, we might recommend arthroscopic surgery.
Okay.
We might also opt for earlier surgical intervention for high-level athletes who need to return to their sport quickly.
And of course, if we diagnose acute DRUJ instability, we're likely heading straight to the OR.
Precisely. Now, the specific surgical approach will depend on the type of TFCC pair we're dealing with.
Okay.
For those type I tears, which are acute injuries.
Right.
The treatment can range from simple debridement to more complex repairs, even augmentation procedures.
So even within type I tears, there's no one-size-fits-all approach.
Absolutely. And for those type 2 tears, which are more chronic and degenerative, the treatment usually involves arthroscopic TFCC disc excision, wafer resection, and sometimes even shortening the ulna to address that ulnocarpal impaction.
It seems like having a solid grasp of Palmer's classification is absolutely key for understanding both the pathology and the surgical approach.
It really is. It helps us tailor our treatment plan to the specific needs of each patient.
So we've covered a lot of ground on the TFCC, but wrist arthroscopy isn't just about the TFCC, right?
Absolutely right. It has a wider scope of applications.
Let's explore those other uses of wrist arthroscopy before we wrap up this part of our deep dive.
Think of wrist arthroscopy as a Swiss Army knife for wrist surgery.
Okay.
It's incredibly versatile, allowing us to address a wide range of conditions beyond TFCC tears.
Okay, I'm intrigued. What else can we do with wrist arthroscopy?
Well, imagine we have a patient with persistent wrist pain and swelling.
Yeah.
And we suspect inflammation of the synovium,
Okay.
the lining of the joint. We can use arthroscopy to take a synovial biopsy, sending a sample to the lab for analysis. This helps us rule out conditions like infection or rheumatoid arthritis.
So arthroscopy isn't just about fixing structural problems.
Right.
It can also help us get a closer look at the tissues themselves.
Precisely. And if we confirm synovitis, inflammation of the synovium, we can perform a synovectomy, removing the inflamed tissue arthroscopically. This can provide significant pain relief and improve joint function.
That's amazing. We can actually treat the inflammation directly without making a large incision.
Right.
What about cartilage problems?
Yeah.
We talked about grading cartilage lesions.
Right.
But can we do anything to fix them arthroscopically?
Yes, indeed.
Yeah.
For smaller, localized cartilage defects, we can perform chondroplasty, smoothing out the roughened surface of the cartilage.
Yeah.
It's like sanding down a rough patch on a piece of wood, creating a smoother surface for the joint to move on.
So we're not just diagnosing,
Right.
we're actively treating these cartilage lesions.
All right. And let's not forget those pesky loose bodies.
Oh, yeah?
Sometimes fragments of cartilage or bone can break off within the joint,
Right.
causing pain, clicking, and catching.
Wow.
We can remove those loose bodies arthroscopically,
Right.
restoring smooth joint movement.
It's like taking a tiny vacuum cleaner and removing all the debris that's causing trouble in the joint.
That's a great way to visualize it. And wrist arthroscopy isn't limited to cartilage and synovium.
Okay.
We can also address a range of other conditions.
Yeah.
Take ganglion cysts, for example,
Oh,
these
yeah.
fluid-filled sacs that often pop up on the back of the wrist.
I've seen those. They can be quite painful.
Yeah,
Can we treat those arthroscopically?
absolutely. We can use arthroscopy to remove ganglion cysts.
Often with better outcomes and faster recovery times compared to traditional open surgery.
That's fantastic. What about joint contractures?
Yeah.
I remember learning that these can limit wrist motion.
Right.
Can arthroscopy help with those?
Yes. Sometimes we can release contractures arthroscopically,
Okay.
improving wrist range of motion and function.
Uh-huh.
It's all about restoring that smooth gliding motion within the joint.
It sounds like we're not just cutting.
Right.
We're often restoring normal anatomy and function.
That's exactly the goal of wrist arthroscopy. And remember those important ligaments we talked about earlier,
Yeah.
the scapholinate and lunotriquetral ligaments.
Uh-huh.
Well, if they're torn,
Yeah.
we can sometimes repair or reconstruct them arthroscopically,
Okay.
stabilizing the joint and
Okay.
preventing long-term problems.
So we're not just diagnosing instability, we're
Right.
fixing it.
Right. And if the carpal bones themselves become unstable,
Yeah.
we have arthroscopic procedures to address that as
Right.
well.
The RASL procedure, for example,
Okay.
is a minimally invasive technique to stabilize the scapholunate joint when the ligament is torn.
It's incredible how much we can achieve with these minimally invasive techniques. What about those more extensive cases where we might need to remove bone?
Yeah.
Can arthroscopy help with those?
Yes. Sometimes we need to perform bone resection procedures. For example, in a condition called Kienbuch's disease,
Yeah.
where one of the small carpal bones,
Mm.
the lunate,
Uh-huh.
loses its blood supply and starts to collapse.
Oh, wow.
We might need to remove a row of carpal bones to relieve pain and preserve wrist function.
Right.
This procedure,
Yeah.
called a proximal row carpectomy,
Okay.
can sometimes be done arthroscopically.
So we're not always trying to preserve every structure.
Right.
Sometimes it's about making strategic removals to improve the overall function of the wrist.
That's an important point. It's not just about fixing everything.
Right.
It's about choosing the right procedure to achieve the best possible outcome for the patient.
Okay, so we've got synovial biopsy, synovectomy, chondroplasty, loose body removal, ganglionectomy, contracture release, ligament repair, and even bone resection procedures. It's amazing how versatile wrist arthroscopy has become.
It's revolutionized hand surgery,
Yeah.
giving us tools to diagnose and treat wrist conditions with incredible precision and minimal disruption.
And I bet there are even more applications we haven't even touched on yet.
Absolutely. We can even use wrist arthroscopy to help with fracture reduction,
Yep.
especially those tricky scaphoid fractures that can be hard to visualize with traditional methods.
Yeah.
And sometimes we use arthroscopy to diagnose unexplained wrist pain when other tests have come up empty.
Right.
It's like our final frontier for exploring the wrist joint.
It's incredible how much information we can gather and how much we can accomplish through that tiny incision in a camera.
It truly is. Wrist arthroscopy has become an indispensable tool for any hand surgeon.
Okay, future plastic surgeons. We've covered a ton of ground today on wrist arthroscopy. We started with the basics, patient prep, essential equipment, and those all-important portals. Then we explored the vast landscape of diagnostic and therapeutic procedures
Right.
from the TFCC to a whole host of other conditions.
We've highlighted key concepts and techniques that are essential for mastering wrist arthroscopy and acing your FRCS exam.
We've gone through a whirlwind tour of wrist arthroscopy,
Yeah.
but I have a feeling there's even more to discover.
Yeah.
It really feels like we've only just scratched the surface.
Right.
Wrist arthroscopy has come such a long way,
Uh-huh.
and I can't help but wonder what the future holds for this remarkable technique.
That's the beauty of surgery. It's a constantly evolving field.
Yeah,
As technology advances and our understanding of the wrist deepens,
right.
we're bound to see even more exciting innovations in wrist arthroscopy.
So what's on the horizon? What can we expect to see in the coming years?
We're already seeing advancements in arthroscopic instrumentation with the development of even smaller, more precise tools.
Wow.
These miniaturized instruments will allow us to access and treat even more delicate structures within the wrist, further minimizing trauma and improving outcomes.
That's like going from standard screwdrivers to a precision toolkit for watchmaking.
Exactly. And imagine the possibilities of 3D imaging in wrist arthroscopy.
Okay.
We could have a real-time, three-dimensional view of the joint,
Yeah.
practicing unparalleled depth perception,
Wow.
and allowing for even more precise surgical maneuvers.
It would be like having a 3D map of the wrist right there in front of us,
Yeah.
guiding our every move.
Exactly.
That could be a game changer,
Right.
especially for complex reconstructions or repairs.
Absolutely. And think about the potential of robotics in wrist arthroscopy.
Oh, wow.
Robotic assistance could further enhance precision and dexterity,
Right.
allowing us to perform even more intricate procedures with greater control and stability.
It's mind-blowing to think about what we might be able to achieve in the future.
Yeah.
But for our listeners who are prepping for the FRCS exam right now,
Okay.
what's the key takeaway from all of this?
The key takeaway is this: never stop learning.
Right.
Wrist arthroscopy is a dynamic field, and the knowledge base is constantly expanding.
Yeah.
Embrace those advancements,
Okay.
stay curious,
Yeah.
and always seek to deepen your understanding of this remarkable technique.
It's not just about memorizing facts for the exam.
Right.
It's about cultivating a lifelong passion for learning and pushing the boundaries of what's possible in surgery.
That's what makes surgery so rewarding.
Yeah.
It's a constant pursuit of excellence, a commitment to innovation, and ultimately a dedication to improving the lives of our patients.
Well said. So, to all those future plastic surgeons out there,
Yeah.
as you continue your journey toward becoming skilled and compassionate surgeons,
Right.
remember this deep dive into wrist arthroscopy.
Yeah.
It's a foundation upon which you can build your knowledge and expertise.
And always remember that wrist arthroscopy is more than just a technique.
Yeah.
It's a testament to human ingenuity and our unwavering pursuit of better ways to heal and restore function.
That's a wrap on our wrist arthroscopy deep dive.
Great.
Thank you for joining us on the deep dive. We'll see you next time for another exciting exploration into the world of plastic surgery. Until then, keep those minds sharp and those hands steady.